All right. Well, just to reorient everybody or to orient folks that weren't with us for the June 13th clinic, this is the second part of a two-part series on managing psychosis in primary care settings. And today, Lydia talked a little bit in the first part about assessments, but really focused quite heavily on the medical management of psychosis and some of the physical comorbid conditions that we often see coincide with psychosis or with people who are on anti-psychotic medications. I'll be honing in on differential diagnosis a bit, and then we'll move into some strategies that each of you can use in your clinical encounters with patients who experience psychosis, regardless of the nature of that clinical encounter. And then I'll also be providing you with some behavioral interventions that are indicated for various psychotic symptoms. I'm going to ask your forgiveness a little bit in this presentation because it's a bit of a kitchen sink. There's a lot to cover with these within this topic, and so I tried to kind of balance breadth and depth, and also be mindful of the fact that there's only so much that you can consume in a 30-minute or so presentation, but I know there'll invariably be questions and people who want me to dive deeper, and I'm happy to do that during the QA or after. Okay, great. So I'll just advance through. I don't have any disclosures myself. The only thing that we want to mention is just to remind you that these presentations are being sponsored by the Substance Abuse and Mental Health Services Administration as part of a 5-year grant that we received to provide training and technical assistance to the Northwest region, including Idaho, Oregon, Washington, and Alaska, under the umbrella of the Mental Health Technology Transfer Center Network. Lydia and our colleague Maria Monroe DeVita co-direct that center, and I'm the training director. All right, so we're going to be looking at some key cognitive behavioral strategies in addition to assessing psychosis. So our objectives for this session are to review updated facts and figures concerning psychosis outcomes to help you guys provide good quality psychoeducation. We'll also be talking about some key considerations relevant to differential diagnosis in a primary care setting. We'll review some core practical skills for a clinical encounter, and then talk about some high-yield behavioral interventions and the steps to skill building. And that last objective, these are things that you can work in within 5 or 10 minutes that you would tack on to a session that could be it doesn't need to be a psychotherapy session. All right, so in CBT, which is my primary theoretical orientation, we're all about providing a rationale and transparency so that people really internalize what we're doing and feel motivated to make behavioral changes. And so applying that to what we're doing here together today, the best rationale I can provide for why it's important for us to talk about these things is that what you last learned about the trajectory, treatment, and outcomes associated with schizophrenia spectrum disorders is most likely outdated. There's a lot of scholars out there that talk about this idea of a half-life for scientific knowledge. So even if you're staying up to date with the literature, or this was really an area of interest for you at some point in your education or early career, we know that these things get outdated, and I would say particularly in the treatment and management of schizophrenia spectrum disorders, there has been an explosion of literature within the last 7 years. So I'm hoping to bring you up to speed on some of that. So don't be confused. I'm actually a new Keanu Reeves fan, even though he's from the 90s, but he's such a mensch. He's such a good person. So don't be confused like he is here in Bill or Ted or whichever one he was in this movie. We're going to walk through this. So I first want to encourage you guys to, just as a mental exercise, take a moment to try to pinpoint what thoughts or images come to your mind when you hear the word schizophrenia. We talk a lot about stigma and self-stigma. We don't talk about some of the preconceived notions that each of us within the medical community or the mental health communities have ourselves. And we'll talk a little bit in a couple of slides about why this matters so much. But I think it's a useful exercise just to check in with yourself to see what kind of connotations you have. And then also, as we're going through this presentation, think to yourself about how do you approach, or do you approach, psychoeducation or on psychosis or schizophrenia with your patients who are either being newly diagnosed or who start seeing you and are coming in with this diagnosis. Is this a conversation that you have with them? And if so, what does that conversation look, feel, and sound like? So this is Ellen Sachs. For those of you who don't know, Ellen Sachs had her first psychotic break in 1977 while she was a Marshall Scholar at Oxford University. And her inpatient psychiatrist at the time, she said she was actually in restraints and seclusion, and the psychiatrist came in and checked on her, and she said, "You've got to let me go. I've got to get to my final exams." And the psychiatrist said, "You're not going back to school. You'll be lucky if you're flipping burgers for the rest of your life." Well, currently Ellen Sachs is the dean of the law school at the University of Southern California. She did go back to school. She then went on and got a JD at Yale. She's got a PhD in psychoanalysis. She has a joint appointment at UCSD. So this was the psychoeducation. This is, this was the information that was being provided about the trajectory of her life and her illness in 1977. Well, in 2017, I met a woman I'll call Jenny, who experienced her first break. Can we move the chat by any chance? She experienced her first break as an undergrad. She was going to college here in Washington State. Her psychiatrist gave her the exact same message, told her, we're going to get the social worker to help you complete your paperwork for disability. I wouldn't expect to be going back to college. She's currently employed, this is 2 years later, as a full-time peer specialist, helping other individuals who are newly diagnosed with psychosis, and she's taking college classes to complete her BA. So a little demoralizing that 40 years later, we have people who are receiving the exact same message. And this message is outdated, needless to say. What I know from training people day in and day out in interventions that are indicated for schizophrenia spectrum disorder, primarily cognitive behavioral therapy for psychosis, is that we typically think about training as this classic trifecta. We need to increase knowledge, skills, and abilities. But that whenever we're training people on how to better manage and treat and facilitate recovery for psychosis, we actually need to go beyond that, and we need to target provider attitudes, because it turns out that attitudes matter. Provider beliefs about psychosis can affect client outcomes. And this is a finding that should not be surprising to us, because we actually see this occurring all throughout medicine to a shocking degree. We see that it's not just the client's attitudes, which also are influential on response to treatment, but the provider attitudes turn out to matter when we look at surgeries, when we look at weight loss, when we look at all sorts of interventions. And there's a link here to a really fabulous TED Talk that it talks about the placebo effects, but how that placebo effect can actually apply, or the treatment effects can actually apply to the providers as well. So we actually need to believe in our clients' ability to recover, meaning to lead a meaningful life that includes joy and a sense of purpose. And training can help facilitate both attitudes about working with people with psychosis and also knowledge. So this is data that comes from colleagues of mine at the Best Practices for Schizophrenia Treatment Center at Northeast Ohio Medical University. They also train a range of providers in how to better manage psychosis, mostly in mental health settings. And what we see in the red are indicative of responses prior to the training. So when asked prior to the training if they want to work with people with psychosis, you can see about 60% said, yeah, I do. And the rest said, I'm kind of on the fence about it. And mind you, this isn't a mental health setting where that's exactly what they're there to do. Their paycheck is to work with people with psychotic disorders. And so they're not that jazzed about it, but you can see after the training, they're much more keen on working with this population. And when we ask them, do you have a clear idea of how to interact with people who have psychosis? Again, we see that the rates went up considerably after the training. Almost everybody after a 2-day training said, yes, I do now have a clear idea. So that's good news for us. Granted, this is a 30-minute didactic, not a 2-day training, but it means that we can really get people more excited about working with this population, and that's going to have a positive impact on you as a provider and your clients. I want to give you a different message than what you've probably heard about schizophrenia spectrum disorders, and that is that recovery is the norm. Expect recovery. When we actually look at data, when we look at 20-year outcomes, what we see is something that can fall into quartiles. So about 20 to 25% will have a first episode of psychosis and will not experience a psychotic relapse. About 25% will experience a subsequent episode, but they'll maintain community ties and tenure. And keep in mind that with every subsequent episode, the risk for another episode does increase. So that's that second quartile. The third quartile is individuals that will require intensive treatment and support. These folks are most likely to be accessing that support in outpatient mental health or intensive outpatient, or maybe even on a PACC team, assertive community treatment team. And they'll have intermittent hospitalizations as they experience, acute episodes. And of the final 25%, these are the folks that will be requiring long-term residential care or suffering severe impairment. And we know that 10% will die by suicide.
Sarah, you might be covering this, but does it matter how they present with their first?
Oh, I'm covering that. Yeah.
Okay.
Yeah, that's a really great question.
Tuned.
Yeah. Okay. So the research has all sorts of definitions of how we define recovery. So we'll start there, and then I'll just put my plug in for expanding our view of what recovery means. But when we look at research-defined recovery, what we're talking about is symptom remission as defined by a scale like the positive and negative symptoms, a syndrome scale, or the CIRAS, these kind of established measures. So we're looking at symptom remission for 2 years or longer. The second metric you can see there is social and vocational functioning for 2 years or longer. And then if both of those are in place, then that's deemed full recovery. So what we see is 5 years after that initial episode, about 47% have achieved symptom remission. About 25% have achieved what's defined as adequate social and vocational functioning. And across both of those categories, we've got about 14%. So that's sort of how the research defines it. When we look at what predicts that recovery, when we're looking just at that 14%, actually it breaks it down. So when we look at symptom remission, really the strongest predictors are the duration of untreated psychosis. So how long was it from the time that symptoms started to interfere with their life to the point where they got some form of treatment, even if it was just a dose of antipsychotic med. It's also what was their level of global cognitive functioning at baseline, because we know that we start to see cognitive deficits even before the first episode. So we look at that point where they're at that first episode, what was the level of impairment? And it turns out that the better the cognitive functioning, the better the long-term trajectory. And then the final is diagnosis, with schizoaffective having a better long-term prognosis than schizophrenia. So that's really important for us to keep in mind, that really that duration of untreated psychosis is where primary care can make a huge difference, because if you feel equipped to be able to intervene in an evidence-based way at that point, then you are really able to shorten that duration of untreated psychosis, because you're not waiting for them to make a connection or take a referral to a community mental health center or a first episode team if that even exists. Okay, summarizing the key findings for recovery. This is a real, I didn't talk about this, but interestingly enough, the severity of psychotic symptoms at baseline does not predict long-term outcomes. So that was not one of the things that you saw on that last table. So people, and actually what we tend to see is the more sudden the onset and the more severe the symptoms, actually the better the long-term prognosis, which is, I think, counterintuitive. But I think part of what's explaining that is the substance-induced psychosis. And so we know that for those where it's truly dependent on the toxic agent, if we remove the toxic agent, then the psychosis resolves. Duration of untreated psychosis, global cognition, and the specific psychotic diagnosis are our most meaningful predictors of, or among our most meaningful predictors of prognosis. And additional predictors that I didn't talk about are individual resilience, the support system, and that could be family or friends. And then I did talk about clinician and client expectations for recovery and the type of interventions utilized. So let's talk a little bit about what the National Schizophrenia Treatment Guidelines recommend. You'll notice there's a lot on this slide. It's because it's not just antipsychotic medication, although that is what most people receive, is just medication alone. And so we know, by and large, individuals with schizophrenia spectrum disorders in our country, only 33% are accessing any kind of care. Of that 33%, most are receiving medication alone. But what our treatment guidelines tell us is best practice is an evidence-based psychotherapy like CBT for psychosis, illness management and recovery or social skills training, case management, peer support, family support, and medications. And that the person's own vulnerability, strengths, resources, assets are really at the center of all of this. When we ask individuals with schizophrenia spectrum disorders, what do you want out of treatment? Take a minute just to look through this list. Because what you will notice, they want to be listened to, they want to have their concerns taken seriously, to be given hope, more information, choice, and collaboration. What I notice is two things. One is everything on this list is something that I would want in my own care. That's good, it's intuitive for us. And two, that all of this is about the process. It's not about the outcome. What they don't want most of their care is, I want my symptoms to be gone, although I think that is something, I know that is something our clients tell us. But when we really ask them in an empirical way, what's important to you, we tend to see that it's the process of care more so than the outcomes of that care. And even when we do see outcomes, I think that last bullet point speaks to outcomes, it's really about feeling better and doing better versus symptom remission. So that's problematic when all of our randomized clinical trials are obsessed with our clinical outcomes, our symptom remission. What they're really saying that they want is, I want to have meaningful connections with other people. I want to have meaningful, work. All right. So primary care is often the first point of contact for individuals exhibiting psychotic symptoms. So you guys truly are on the front lines. And so I have this little question here. Which of the following is the leading cause of new onset psychosis in primary care settings? You can see we're starting to get into our differential diagnosis section. So maybe you could put it into the chat window if you think it's A, primary psychotic disorder, B, if it's secondary to another psychiatric condition like an affective disorder or an anxiety disorder or personality disorder. C, secondary to a medical condition, delirium, or toxic exposure, or D, substance-induced psychosis. If you're willing to take a non-anonymous, de-identified poll and be bold.
Oh, Amy's bold.
Amy's bold. Yeah. Thanks, Amy. Thanks for putting yourself out there. All right, A or D. Anybody else want to hazard a guess here? Awesome. Thank you, Stephen. All right, I'm going to move on. So D and my down. All right, so we got a couple of D. So D is the correct answer. So it is substance-induced psychosis.
Oh,
All right.
Karen put
You
the D last
celebrate.
minute.
You celebrate.
BMO, too late, BMO.
All right. So that is true. That is true. Now we want to keep in mind that with psychotic with schizophrenia spectrum disorders, we're looking at a constellation of symptoms that would include hallucinations, delusions, negative symptoms, cognitive symptoms, and affective symptoms. We don't usually think about that, but you should expect as a rule that there will be some affective element to any schizophrenia spectrum disorder. And that behavior element, that disorganization in thinking and in behavior. When we see that constellation, you should think zebra in that case. But when we're seeing independent psychotic symptoms, then we want you to think horses, right? So we know that psychotic symptoms are not necessarily pathognomonic of just a schizophrenia spectrum disorder, that they're actually considered a non-specific set of symptoms that can be attributed to a range of other conditions. And actually, this study that I referenced first here, that Olfson study, is in an urban primary care setting, and they found that psychotic symptoms among the patients that they were treating were, in addition to schizophrenia, 42% of the time were consistent with a depressive disorder, 40% of the time were happening as a secondary to an anxiety disorder, specifically 25% with a panic disorder, and then 14% for a substance use disorder. So these numbers are really shocking, and it's very, very common that we see psychotic symptoms and our first thought is schizophrenia, but we definitely want to be thinking about what are the potential possibilities here outside of schizophrenia, especially if we're not seeing that constellation, we're seeing isolated psychotic symptoms. And then we know that about 1 in 500 to 1,000 births, the mother will experience postpartum psychosis, that we're more likely to see that when the mom has had previous psychotic symptoms or depressive anxiety symptoms. So it's kind of like this finding that any mental illness can make you more vulnerable to a psychotic disorder, but we need to really be clear about that differential. Because it is so common that we see substance-induced psychosis in a primary care setting, I wanted to spend a little time talking specifically about that. And Lydia did touch on this last time, so I won't spend too long on it, but we want to, obviously, we need to be doing objective tests to see whether there's an active substance, in the body. We also, Lydia talked about, just checking, have there been recent trips where they have been exposed to a toxin, new chemicals in the house, that kind of thing, a new job. Oftentimes, I want to just validate that this can be very, very complicated to tease out substance-induced psychosis from a primary psychosis, because we do see substances being a catalyst for somebody who is at risk for a psychotic disorder, but that the psychosis persists once the substance is removed. And so sometimes it is a wait and see. What we do see is that it's more likely to be substance-induced when we see, it presenting in late adolescence and young adulthood. Well, let me actually go to the next slide because that talks a little bit more about differentials. So when we see a family history of a substance abuse disorder or substance dependence, then we want to be thinking more, this is more likely to be substance-induced psychosis. Or if that individual has a diagnosis of a substance use disorder. When we see antisocial personality traits or a diagnosis, we're thinking more substance-induced. If social functioning is intact, that's a big red flag that this is a substance-induced psychosis. Where we see an acute onset set of symptoms, where we see visual hallucination, and if there are delusions, these are most likely to be paranoid and not inclusive of other types of delusions. We're more likely to be seeing a substance-induced psychosis. We typically don't see a negative symptom presentation for substance-induced psychosis, and we typically see better insight in and sort of more distress secondary to these psychotic experiences. But again, if you're catching somebody early, if you're catching them in that kind of high risk period, then it's a little bit of a wait and see, because some of these things it might be the case that social functioning is still intact. It might be the case that they still have insight intact. So let's talk about if you're catching somebody early and following them. That we used to talk about this as the prodromal period, which of course is a retrospective kind of diagnosis, if you will, or categorization. It now goes by several terms: clinical high risk, ultra high risk, psychosis risk syndrome, at risk mental state. There is sort of the gold standard for measuring or assessing whether somebody is at clinical high risk or ultra high risk for a psychotic disorder is a semi-structured interview called the Structured Interview of Psychosis Risk States. It used to be it used to have prodrome in there, so the acronym is SIPS. There are 2 trainers in all of the United States. It's very hard to find people who've been trained in this measure. So we'll talk a little bit about what are the things to be looking for to determine whether somebody might be at a clinical high risk state. The typical age range that we're seeing somebody in this high risk state is between the ages of 12 and 25, with 85% of people developing their first episode by age 25. I'm going to skip through this. So this was the largest study that I know of individuals in this clinical high risk period. This was done in the UK, and it was an individually matched case control study. So they had 93,480 patients across 530 primary care practices in the United Kingdom. They had about 12,000 who'd been diagnosed with a schizophrenia spectrum disorder, and then they had 82,000 control participants, so 7 controls per case. And their key findings here were that individuals who progressed to a psychotic diagnosis had consulted with their PCP an average of 14 times more often than controls prior to the index diagnosis. So that's good news for us, because it means people are coming in to their PCP more often. And this is with a constellation of concerns. Neck pain, I mean, this is really non-specific. So they're just accessing primary care services more often than those who do not go on to develop a schizophrenia diagnosis. What we saw in the folks that did have that the schizophrenia diagnosis was that they were more likely to have a diagnosis of any other mental illness. And so that increased the risk substantially. And symptoms associated with an eventual psychotic diagnosis included most commonly, or the biggest sort of odds ratio here, the biggest likelihood of developing into schizophrenia were bizarre behavior, and then interestingly, suicidal behavior, followed by cannabis-associated problems, depressive problems, and then some blunted affect. And then we see, again, beyond that, we're starting to see ADHD, OCD, so we're seeing a lot of other kinds of mental illness that were cropping up before the psychosis emerged. When you're making this differential diagnosis, I cannot emphasize enough how important it is to talk to someone other than the patient. You have to get collaterals in there, because what you're looking for are changes in behavior across settings. And this, you know, anytime we see, just thinking about that last slide, anytime we're hearing about just bizarre behavior, uncharacteristic behavior, that should set off alarm bells in your head. Anytime we're seeing, you know, a sudden drop in grades, much more isolation, and that could be gradual or sudden, we want to be thinking about this person is at high risk. We don't know how this will ultimately go. About only 30% of the people that get categorized as clinical high risk for psychosis do end up transitioning into a psychotic episode. but it's certainly something that should be raising our hackles, and we want to be bringing this person in more often. We want to assess both with the individual themselves and with their collaterals, what's the nature of their thinking? Is it kind of, are we seeing evidence of magical thinking? Are we seeing evidence of just illogical thinking? That's another big red flag. And then any evidence of negative symptoms. Are they showing less emotional range? Do they have less energy, less motivation? The challenge here is that typically, again, thinking about our age group here, 12 to 25, we've got pre-adolescents and adolescents who are doing a lot of isolating, who do have changes in behavior, who may have a sudden decline in grades. So again, these are sort of these non-specific symptoms that we just mean we need more contact with this person and with their loved ones. We want to find out, is this acute or gradual? And again, nothing here is neither of the responses to that rule out a primary psychotic disorder, but it helps us better understand whether this might be a substance-induced or something related to another a mental illness or toxic exposure. Do we have previous diagnoses and related medical conditions? And of course, is there a family history of schizophrenia? That does increase the risk, particularly if it's a monozygotic twin, if it's a parent, and then after that, if it's another kind of sibling. Beyond that, it's really not that predictive, beyond that immediate family. Engagement. How are we doing? I think we're okay on time. Okay. So obviously, we talked about that duration of untreated psychosis. So we want to make sure that we're keeping people coming in to see us. And that we're able to keep tabs on them, and that if a psychotic episode hits, we are able to introduce an antipsychotic agent as soon as possible. And Lydia talked last week about this. This is often going to be a lower dose, but we still want to get something in there. About 80% of individuals in a standard, care setting, so not a first episode specialty team, will drop out within the first year of treatment. That's a huge dropout rate. So interestingly, our folks with schizophrenia before that first episode are coming in 14 times more often than their peers, but then after that psychotic disorder, they are way more likely to drop out of treatment. And so when we're thinking about engagement, we need to be thinking beyond just that individual. We want to be thinking about how can we reach out to the community so that there are people who can be alert to the signs and symptoms of psychosis, and maybe even, and this is our job as trainers who work with people who have contact with this population, clergy members and teachers and counselors, that folks have a little bit of skills in their tool belt to really know how to talk to people with psychosis. Engaging both individuals and families, and really putting their goals for treatment at the center so that they feel like, again, going back to that process, I feel listened to, I feel heard, I feel understood. I know my goals matter in this treatment. And then peer involvement could mean peer specialists, but that I know is a luxury to have in any setting. But it can also mean bringing in people, maybe this 17-year-old wants to bring in their girlfriend and not their mom, and making sure that we're engaging the people that are important to them. Okay, when we are providing psychoeducation to individuals, I think it's really important that we have a good handle on more than just the biological model, which is really this kind of dichotomization here. The biological model of schizophrenia spectrum disorders has really classified this as a brain disease or a biochemical imbalance. And the implication there is this is something that happened to you and not something that you can well manage. And so we'll manage this with biological approaches, medication, other, maybe ECT, depending on the severity and course. The cognitive model is really, this is not your fault. This is an understandable reaction to stress or to biological vulnerabilities. And we know that the way that you think, understand, and behave will make a difference. And that's really underscored by the stress vulnerability model, which has been around for 40 years. And it's really all about this interplay between our genetic, biologic, or early life experiences that create a vulnerability to developing psychotic symptoms, coupled with stress that catalyzes the psychosis. So you can think of everything above that diagonal line as the land of psychosis, and everything below it is not. We know that this is a dynamic kind of thing where people will move in and out of psychosis based on that vulnerability might not change, but based on the amount of stress that they're experiencing and how well they're managing that stress. So what that means is that they actually have a great deal of influence over their symptoms and over the course of their illness. And our job is to help them really kind of manage the vulnerability on one end. And the best way that we know how to do that is through the medication, and also to help them manage the stress, because we can't take away somebody's stress entirely, but we can help them be better equipped to manage that stress, and that can have a huge effect on their symptoms. So this is something that I would recommend everybody talk about to their clients, really just the way that I just did now. And then thinking about in any clinical encounter, what are some of the most critical ingredients here? One is just active listening. So 80% of communication is nonverbal. So that has to do with us and how we're listening. Sometimes we're doing collaborative documentation and we're facing a computer and we're not making eye contact with our client. So really making sure that our clients are seeing, our patients are seeing that we're engaged, we're listening, we're mindful of our own sort of nonverbal cues, and then picking up on theirs. You know, when are they getting more uncomfortable? Are we in kind of the tug of war here over a belief that we're categorizing as a delusion, and they're kind of checking out? And part of active listening is really not thinking about what we're going to say next, but really listening to what they have to say with an open mind, even if it's kind of against our medical advice.
Sarah, this is important for any patient that we see, right? Period. Is there something in particular that we should also be aware of for patients with psychosis that we should, to kind of underscore why this is so important for that population?
Yeah, I mean, I think trust is huge, right? Thinking about that 80% disengagement within the first year. Our clients need to trust us. So one of the things, I mean, this is sort of active listening, but also acting in ways that engender trust is I take notes and I talk about the fact that I take notes. And I'll tell them, I really want to make sure I'm capturing what you're saying in the way that you said it. So you'll see me taking notes from time to time, and then not holding my clipboard like this, but really putting it on the table so that they can really feel like I'm trustworthy, I'm transparent. I think with regard to empathy, right, it goes back to what do service users want? And one of the things that they want was to feel listened to be listened to. So that's active listening, but it's also that empathy piece, right? It's being able to kind of paraphrase what they're saying to reflect feelings, and the kind of, the messages that they're giving to us. This number 3 item is something that we consider to be a non-specific therapeutic factor. This is something that, independent of anything else we do in therapy, we need to convey warmth. We need to convey this genuine positive regard for our patients. And the way that this plays out and should play out is I'm not, it's not I'm the doctor, I'm the expert, and I'm giving you advice. It really is I'm the expert in helping people who have similar experiences and symptoms, and you're the expert on you. And so together, we're going to put our heads together and find out what's the best game plan for you here. This is a collaboration between the two of us, and really again underscoring our expectations as critical. Really conveying this belief that you can do this, that we can work together to get you to a better point and to help you overcome the challenges you're experiencing right now. Whenever possible, we know that individuals with psychosis have difficulty with abstraction. that's part of the, frontal lobe deficits is, they really need the communication to be concrete, specific, direct, doesn't mean crass, but really, just say what you mean. I think sometimes we do some tiptoeing around individuals with psychosis, particularly when they're experiencing a lot of perseveration around delusions or a high degree of distress, and we don't want to tip the boat, rock the boat. Just, say what you mean. Our clients are not that fragile. And so really, help them to kind of get at what is it that's causing the most distress for them. And then let's make a goal around that together. And we're both going to be accountable to that goal. We're going to collaborate on this specific action plan and check in about it every time. And then don't avoid discussing delusions, but when in doubt about the delusions or you're worried that, the delusions have gotten worse, then you want to ask questions rather than assume. So that gets at number 5. Really be thinking about, rather than advice giving or making assumptions about what's going on with the client, asking these gentle, curious, open-ended questions. It does a couple of things. One is it helps you understand things from their perspective. 2, it helps you both collaboratively explore thoughts, feelings, and behaviors, and in a way that the client is not likely doing independently. And so you can understand, God, why was it that you were so afraid when you got your appointment reminder? And then the client says, well, I was thinking that you were going to see that I was doing worse and you were going to fire me, or whatever it is. So really, kind of getting at, not assuming we know, but really getting at what's going on with the client. And then the other thing it does is that it models curiosity for the client. The client is making a lot of assumptions about what's going on that are typically not the most helpful. And we want the client to start to be inquisitive about their own thoughts or their own behaviors, to really start to ask some of these Socratic or open-ended questions themselves. It's okay to self-disclose. We talk about therapeutic self-disclosure, so really disclosing things with a specific goal in mind. And so one of the ways that this plays out for me very often is when I'm meeting with somebody who has thought disorder, I will make a lot of blips and kind of lose my train of thought, and just kind of say, God, that happens for me a lot. Tell me about times when that happens to you. I notice that sometimes you get you kind of stop what you're saying all very suddenly, and you're really just kind of normalizing, you're aligning with the client, you're modeling for the client. We talked about number 7 in terms of transparency, but also really kind of promoting choice and collaboration, asking those questions and really trying to show that they're an active agent in this, in the treatment, providing accurate information. We'll talk a little bit about psychoed. I don't have a lot of time left to do that. I'll just say a bit about the last one, which is avoiding confrontation and collusion. So this comes up a lot when we are working with somebody who has delusions or hears voices. I was working with a woman who had delusional disorder for some time. She, I think, would have benefited from medication, but was very resistant to that. And about 6 months into our treatment, she agreed to meet with a psychiatrist. She was scheduled, this was in another state, she was scheduled with a resident, and the resident says to her, so I understand you need to take an anti-psychotic medication for your schizophrenia. And she was like, what are you talking about? I don't have schizophrenia. You don't know what you're talking about. She almost fired me. She certainly fired the resident. But it really damaged the relationship that she had with her treatment team. And I think it's really important that we walk the line here, that we use the client's language, and that we can align with the client in a way that's not collusion, right? So what that might look like is empathic disagreement, right? It is, I'm having a really hard time seeing that, but I see that it's causing you distress, and I really want to help you with that. Or I see that this is a big concern of yours and that you want some relief from that. So really finding that place of empathic disagreement where it's not collusion or confrontation. I'm going to skip through this, but I know my slides will be available to everybody.
Sarah had paused here for a question to see if there's anything around the stuff that she's been talking about, if there are any questions right now before we get into some of the behavioral stuff. As people are waiting, I did have one question. You had mentioned how the resident had said, these are your meds for schizophrenia. One scenario that I could see playing out is, I write my note, I submit it on the diagnosis is schizophrenia that they can then read in their chart online. How do you kind of work with that from using their language to using the ICD-10 codes for coding?
Yeah, that's a great question. And in fact, that was how she came to our clinic, was that she had accessed her notes and she had seen that was a diagnosis of schizophrenia. And I think, we have to be ethical in our practice, right? So if we think that is the most appropriate diagnosis, then we put that in as the diagnosis into the EHR, and I think we facilitate a conversation around that. And that's usually where I start with psychoeducation: is what do you know about this diagnosis that you've been given, and just see what do you think about it. Just see what their reactions are to it. And then I talk about what are the things that, whoever it was who provided the diagnosis, or maybe me, what was it that made us think that this was the most appropriate diagnosis. And then I think we're humble too, right? Because there's actually a really interesting paper that just came out this month about this whole idea of psychiatric nosology and how it's really very imprecise, right? So we don't know how something is going to manifest over time. Right. But I think oftentimes what's so scary about that diagnosis is that people think that they're being labeled as crazy, and that it's a diagnosis that you don't walk away from, right? And so that gives me an in to find out what is it that's most scary to her about that diagnosis, and then to correct some misconceptions and myths using some good quality psychoeducation, which includes first-person accounts.
Great. I think it highlights the importance of being able of talking about what you're documenting, really sharing and having a communication around what you think is going on. And then I was struck by your comment, Kari, about these skills, these 10 commandments are for anybody we're interacting with. Why would psychosis be different? And what struck me is just thinking about, from the perspective of primary care providers, just the discomfort, the inexperience of being confronted with psychosis. It's different from being confronted with somebody, meeting with someone who's depressed or anxious. Most people have a lot of experience with that, but just trying to think about the right thing to say, or how to be a more active and engaged listener when you feel like you don't have the skills to do that. And just really curious about people's experience, if that's what the difference might be, if that really just feels fundamentally different. They're just different interactions, and just thinking about what we bring to those interactions.
Yeah, is there, on the call, or is there anyone who feels brave to kind of talk about what that's like for those of you that aren't used to dealing with patients that have psychosis?
Especially with brief contacts, right? I mean, it's not like you've got these hour-long psychotherapy visits. You're trying to deal with some presumably presenting somatic complaint, and trying to negotiate potentially delusions or distorted thinking or tangential thought process, and really trying to figure out how to manage that.
Yeah, I mean, I'm thinking about, Patricia and Richard and Jerry and others on the call who, I know you guys do a lot of primary care. You may run into patients like this. Do any of you, have a sense of what that's like, or had a chance to,
or tips about it,
or
how
tips for
well,
or anything that we're saying here that might be helpful for how you navigate those interactions?